Uh, Good morning. Alistair Burns is my name, and I'd like to welcome you to this webinar, a joint webinar between the Memory Services National Accreditation Programme, MSNAP, and the NHS. As I say, Alistair Burns is my name. I'm your National Clinical Director for Dementia, and it's my pleasure to host the webinar this morning. We know that the pandemic, COVID-19, has forced quite a change in the way that memory assessment services have been operating. There have been challenges in terms of looking at different ways to organise things, and we know there are now a number of people on the waiting list who haven't had the opportunity to have that assessment. A few of us and many people on the webinar have been involved in the issues that we've been discussing in terms of how we maintain high quality care and assessment through these changed times, what we do about various investigations, brain imaging, blood tests, etc., and also how we ensure that the quality of the diagnosis and the quality of care is maintained. So we've got a packed programme today up until 11 o'clock. Sinead, could I have the next slide, please? I just have a couple of the housekeeping announcements to make. You will have joined the webinar as attendees. So if you have a question, if you type it into the Q&A box, if you could let us know if there's anyone in particular you would like to answer the question. So if it's directed to anyone in particular, if you could let us know. If not, we'll do a direct. And if we're unable to answer every question, we'll make sure that as part of the follow-up, we'll get an answer to you. So this is about your experience and questions, and it's really important that we get an idea of your own views on this. Could I have the next slide, please, Sinead? In terms of the active discussion, please feel free to contribute. There are a number of people on the call, but if you raise your hand, we will then unmute you. And I think there's a little button for you to confirm that you want to be unmuted, and then we can invite you into the discussion. As I say, there are a number of people, so time is a bit limited. So if we could make any questions in the discussion brief, and to anyone answering, if the answer could be brief as well. If you are joining on the telephone, press the star key followed by 9. That'll essentially unmute you, and you'll tell that the host has unmuted you. So when we get to the Q&A, there'll be some will come on the on text, and I'll do that, and others who want to speak, let me know. The discussion and the webinar is being recorded, and it'll be available afterwards. And just in case I forget at the end, to thank everyone involved, but also to announce the next MSNAP forum is on the 12th of October, and details are going to follow. So it's a great pleasure to introduce our first speaker, Ben Underwood, a consultant psychiatrist and Deputy Medical Director at the Cambridgeshire and Peterborough NHS Foundation Trust. And Ben has been a supporter of, looking at new ways of working for some time, and has a lot of experience in this area. So Ben, it's a delight. Thank you very much for your time and your busy schedule to come and speak to us. So over to you.
Thank you very much indeed, Alistair. It's a real pleasure to be asked. This is, as you point out, I'm a jobbing old age psychiatrist. I'm actually doing memory clinics and trying to keep those going. And I'm also a Deputy Medical Director and Clinical Director in Cambridgeshire, so I'm responsible for older people's services. And that includes during the time of COVID. So I've been sort of operationally grappling with this as well. So I've got involved today, I think, more precisely because actually Alistair put a call out earlier this year to a variety of clinicians involved in this sort of thing, from general practice, from old age psychiatry, from neurology, that came together to try and help as a group deal with these problems of how we deliver safe and effective memory assessments during the time of COVID, and to share learning and good ideas, hopefully, across the piece, and then keep that going as things evolve. That's actually led to a published document, Memory Service Assessment, New Ways of Working, by the Yorkshire and Humber Clinical Network. And if someone is good enough to ask me that question in the question and answer box, I'll put the web link in there in a minute. And there's also an excellent similar document from the London Clinical Network. So we'll put that in there as well. So my job today really is to be a bit of a warm-up man. So I'm going to talk a little bit about some of the things that came out in that document and the principles. And then I'm just going to we'll teach you to do some egg sucking, because we'll go through the process of the memory assessment. But actually, as a group, we found that a really helpful way of breaking down what looks like quite a big and very challenging problem into steps that we could sort of deal with and have some ideas. And I'll tell you some of the things in that paper and some of the things that we've experienced in Cambridgeshire. I'm genuinely really interested to see your experiences, and if you think I'm wrong and talking nonsense, do put it in the chat bar or in the question and answer, and we'll deal with that. And I see Vicky's already put the link in, which is fantastic. So the first thing that we tried to do as a group were think about ways in which the principles that should underpin what we did. And there are effectively three. So the first one is that our process should be needs-led. So we should be dealing with the requirements of our population, not what we can offer or what our resource dictates. We're the group was very strongly minded that we should have equality of access. And I think the first thing for that, we are people who deal with older people. It would be pretty sad and shameful if we didn't stand up for older people. So there are anxieties that there may be some age discrimination. So can older people manage the tech? Do they have the tech kit? Can they manage it? Are they more likely to be assailed by specific disabilities, for example, poor vision or poor hearing, which would make things more difficult? And so it was essential that those things don't screen people out. There's also a danger perhaps of being a bit pejorative, that we see older people as not being able to do these things. And I must say, in my own experience, I've seen many people where ask them about their social contacts and say, well, of course, I Skype my daughter every week. But not everybody can do that. And the other thing was that we were live to a variety of challenges around the country in terms of the sort of demography, and some areas where English won't be a first language for many of our patients, and making sure that we get our interpreters involved, and that didn't discriminate against people. I have to say, I've been actually powerfully persuaded along the way that there are advantages as well as problems here, that things that can help us. And as a rare user of interpreters, but certainly having the experience of sitting there waiting for one to turn up that doesn't show, and then we all look a bit embarrassed, or trying to get language line and grapple with that on the telephone, having an interpreter join us in a video conference actually sounds like it could be potentially positive. And the last principle that we drew on was that we can't just sort of do this and say, oh, well, look, this is how it's going to be. We need to dynamically monitor it, tweak it, change it, and make sure we're getting it right. And in particular, think about risks. Okay, if we can have the next slide. So here we have the beginning. Now, all of this will be incredibly familiar to nearly all of you, and I'm not going to go through each one in excruciating detail, but there are some issues which I think we're beginning to experience at each stage. And the first of those is triage, because the essence of the problem here is that the risk and benefit of seeing people has shifted with COVID. There is increased risk of us seeing frail elderly patients and transmitting COVID to them. And I think increasingly the literature is clear that I think in the early days there was some question mark as to whether people with dementia were more or less at risk, but I think the evidence is becoming clearer that they are at risk. And they also have many other risk factors for death in COVID, such as advanced age, which travels with dementia for obvious reasons. So therefore, I guess the bar's shifted potentially on triage. Many services will not have said no for a very long time, but actually now there may be some where you can question the value of seeing the patient. There was discussion around blood screens and whether blood screens were the right thing to do, and I think pretty much the group was of a mind that actually this is still essential if we really need to want to make a secure diagnosis of dementia and not miss things. And certainly in Cambridgeshire, the general practitioners have ordered themselves in quick time and are able to deliver these blood tests. Another thing that's really helped us actually is having access to the local acute hospital's electronic note system, and we find that many people have already had those blood tests as they've gone through the hospital, and indeed many have had imaging as well. So then there's questions around some services had rules, the blood tests had to be within 6 months. I think we need to be pragmatic. Myself, my personal view would be we need to be pragmatic and think about the time frame of the evolution of the problem, and whether those blood tests are in a reasonable time frame. And one may say the same about imaging. They had a CT scan 3 months ago. Do we really need to do another one, or 6 months ago? Those will be balances on each patient. Obviously, there's a variety of methods of assessment. Video conferencing now has been rolled out pretty much everywhere via a variety of different platforms, both in general practice and in secondary care, which is super helpful. But also there's possibilities of telephone assessment. I know my colleagues in neurology and Addenbrooke's have been doing a fair amount of that, and they've had some positive experiences. There are issues around gaining the history from the patient and collateral history from their relative. Though actually, again, in my practice, I found that suddenly the daughter in Australia can join us through the magic of the internet, or people around the place, or people are able to join and give collaterals because they're able to take a little bit of time out of their working day without having to perhaps drive all the way back to Cambridge and bring mum or dad into the clinic. Cognitive examination is a hot topic, and people have been quickly moving to generating electronic versions of their various tests. Some are well established, things like TIM test. There is some evidence for others like ADAS-COG, and there is an electronic version of the ACE, which we're generally using in Cambridge and Mini-ACE, but there will be issues and questions around that. Physical examination is a good one. I've been caught out myself. I said to the patient, "Can I see you walk, please?" And they simply walked off the screen, and I'm not sure I learned much other than they could rise from a chair pretty quickly. But I've also been surprised again by, I explained to a patient, well, normally I would now take your pulse, and the husband of the patient said, well, actually, I've got my blood pressure machine here, doctor, because I've got high blood pressure myself, and we self-monitor. Put that on his wife, who was able to demonstrate the pulse and its regularity through the monitor and the blood pressure live on the screen. Of course, there are risks to doing that as well, but we are learning that we can do more and more. I know Jeremy is going to talk in detail about imaging, but I think around that there may be difficulties with availability of imaging because it's taking longer to get people through scanners because they have to be cleaned and so on. There are some backlogs, and there will be maybe harsher triage, and also we're finding some patients are pretty reluctant to go up to the hospital. So there is patient choice there as well, and that is completely understandable in the context of the epidemic. I wonder if I can have my next slide. I'm sure all of this is very familiar to you because you all have been living this as we've gone along as well. So issues of contention, I'm aware that other parts of the people, my colleagues in other parts of the country have told me there are sometimes difficulty in getting blood, and actually who's going to do that, whether, where the responsibility sits, and revision of shared care and some issues there. There's a question of balance. Where do we say, are we going to say that we're going to do absolutely every consultation remotely now because that's the safest thing from infection control? Or are we going to say we're going to do some in face-to-face, or are we going to say, well, actually, do you know what, we're just going to ignore this COVID, and actually the importance of getting the diagnosis right and being in the room is so high that it's worth the infection risk. If people can't be assessed remotely, what do you do? There's then another risk assessment that needs to be made. Are we going to go out and see them face-to-face? Is that consultation worth it? Because, of course, remote consultations are very safe from an infection control point of view, but that balance shifts as you see people, and therefore, again, there are questions about seeing people. We've talked about some of the issues around imaging. And the other thing that I'm powerfully swayed by is I'm getting increasingly high quality data that's increasingly localized. So I see very high quality data twice a week sent to me on the level of virus in Cambridgeshire hospital admissions and a squillion other data points. So as that shifts, our risk and benefits will shift too, and I think we need to keep that in mind. We talked a lot about problems, but actually I've been struck by some of the benefits. So in terms of equality, I cover Cambridgeshire is a fairly large county. It's quite rural, and quite frankly, it's easier to recruit doctors to some parts of it, like Cambridge, than it is to others. which are perhaps more remote. Remote working allows us to be much more equitable, and where we used to have a rather patchy waiting list around the county, that's just not sustainable when we're doing remote assessments, because where there's a long list, we can simply target our resources there, and therefore I think there will be more equity. So there are definitely advantages. And too quick maybe sometimes to see problems. So I can recall one patient where the patient was referred and they absolutely insisted the patient had to be seen face to face. And I said, why is that? And the answer was because they are deaf and they lip read. Well, if we see them face to face, I will be wearing a mask, so they won't be able to lip read, and they'll have a rather muffled voice, which you may think is a blessing. But if we see them remotely, which we did, they can lip read perfectly well, and actually with noise cancelling headphones, they can maximise their hearing. So for them, even though on the face of it, we're better off face to face, the remote assessment was of benefit as well. And how do we learn from this? How do we take the best from this? How do we use it? How do we maximise productivity? In my own organisation, each month we're saving £70,000 just in one part of the trust in decreased mileage. Well, that is money that hopefully we can spend on other things that will be useful. If we're not driving around the countryside all the time, we should have more time, we should be able to see more patients, and we should be more productive. So that is super positive. Okay, if we could go to my last slide, and then I will stop rabbiting on at a rate of knots. So this is stuff that I thought people might be interesting and people won't have seen. So in my county, I've been lucky enough to work with a fantastic colleague, Anna Forrest, who's a psychologist who has really led on some of this work on remote assessment. And so I just pulled our trust data as to see what information we had on how things are going. So I only had it to the end of 30th of June when I made these slides, but we already had over 2,000 clinicians had done video consultations and filled in the survey. And in the view of the clinicians, this, I should say, is for all patients, not just older people, and certainly not just memory clinic, but lots and lots of different services using video consultation. But actually, the clinicians were pretty happy with it. They scored it at 4 out of 5 on average, and they felt that the patient experience was also a 4 out of 5. So then I've tried to look actually, well, okay, that might be great, but if we're seeing lots of 20-year-olds, maybe it'll be a different kettle of fish for older people. So I pulled the data on 240 patients between 51 and 71, and they also were scoring very high scores, really, for the satisfaction with video consultations. So they were scoring 4.4 out of 5 for communicating, and also very high scores for their enthusiasm for choosing video consultation next time. But I also had a little bit of data, just 72 now, it's getting thinner and thinner, on people over the age of 71. They were positive for communication and also positive for choosing the video consultation again. My own personal feedback, one of my patients said, "This is brilliant, doctor. I don't have to drive all the way to your clinic and find parking." And I thought, yes, I feel exactly the same way. However, but you could argue that this data is only those who've successfully had a video consultation. It might be different elsewhere. But we do indeed see that 80% of people 50 to 70 can access it without help. But actually, it was a minority of those people over 70. They needed someone with them to give them some help. And then lastly, in older people's mental health, absolutely specifically, I had data on 50 patients, and the clinicians were scoring their sort of 3.94 out of 5 for their experience. So I take that as a round of being actually probably those scores are more positive than we would have guessed before we embarked on this. And so I come full circle and say I think there's a lot of good and positive things that we can take out of this, which will be good for our patients.
Ben, thank you very much indeed. That's you've got us off to a fantastic start. That's it's really good. We have a couple of minutes before we move on to Becky. There's a couple of things in the chat, Ben, and if you've a minute just to respond very quickly. About people with learning disability, a very good point, Jane. Thank you very much indeed. And I think, Ben, you would agree that the issue of people with learning disability in Robo is very important. And certainly in my memory clinic, I've now had probably more contact with colleagues from the Learning Disability Service than I used to. So a very important point. A question about the online ACE. I think, Ben, you had sent me the information before about the online ACE. If we can get it in the Q&A box, we will. If not, we can send that afterwards. A question, Ben, about the numbers of people who, in a sense, you were giving the remote diagnosis to compared to before. That was a question from Colin. We might come to that. A very interesting point about the issue of the mask, and certainly some of my colleagues have said that the most difficult thing they've had to do is to give the ACE face-to-face using a mask, and so using video, very important. One of my colleagues said the other, you extolled the virtues then of remote consultation, and one of my colleagues said, well, the real reason is that patients and the families don't have to tidy the house in anticipation of your visit, so they can just they can turn the camera. So all sorts of things there. Then just in terms of a sense of the numbers of diagnoses that you're giving now compared before, any quick response for that from Collins, and then we'll move on.
So if so the short answer, Colin, is I think no. So I think if I've interpreted your question properly, you're asking me, are we giving more are we more likely to diagnose someone with dementia or less likely to diagnose someone now we're using remote assessments? And I have the data from pre, but I don't have enough data yet from post and whilst we're using remote assessment, because our memory clinics in Cambridgeshire, we took the decision to entirely suspend them for some months at the COVID peak, and they are now up and running again. But I don't think we've generated enough data to answer your question. But yes, it is very interesting because if there is a difference, then that suggests that the remote consultation is not the same as being in the room. So that's a great idea, and I will make sure I can find that data. Thank you.
Great, thanks, Ben. And a couple of other questions. A copy, if it was possible to get a copy of the survey that you did. Again, we could do that because a lot of people are interested in that. A question from Pip about the patient experience, and later on Ella is going to talk a bit more about that. And in terms of the issue of validation, and that's a very important point, Devon, in terms of looking at the issue of the validation and people from the Turkish language. I think that's really important. The only thing that I think I would observe is that just remember, the tests that we do, these cognitive assessments, are a guide. They're a guide to our clinical decision making, and validation is clearly very important, but using them as a guide. And I know that before the colleagues have said that if we look at the opportunities that you've articulated very well, Ben, of doing things in a different way, giving people permission, perhaps going back to the skills of history taking, and perhaps not relying on some of the automated things. So validation is clearly very important, but giving the opportunity for us to exercise our clinical judgment is important. So a number of questions that we'll come to later, questions about the accuracy of the remote diagnosis. In fact, we're now probably moving to the term remote consultation and a virtual diagnosis, because some people said if we talked about a digital diagnosis, how can you do that on the phone? So I think it's time to move on. Thanks again, Ben, for getting us off to a tremendous start. There'll be a chance later. We've got some time for Q&A later. We'll come back to these things. But our next speaker, it's a great pleasure to introduce Dr. Becky Dow, a consultant clinical psychologist from Oxford Health NHS Foundation Trust. And Becky, you're going to take us through the really important issue of the neuropsychological testing, how we do it, and what some of the opportunities are. Over to you, Becky.
Thank you very much, Alistair, and thank you to Ben for describing a situation that feels very similar to maybe many of us across the country. So yes, my name is Becky Dow. I'm a consultant clinical psychologist, and I actually work in the Buckinghamshire part of Oxford Health. So if you could move to my next slide. I think it's really important just to point out variability across the country and just give you a sense of where we are in Bucks, because I feel that really sets the scene for what maybe is very different in what people are trying to achieve. I'm going to try and give a sense of where the clinical psychology service is with us, because again, there's a difference in how involved clinical psychologists are, the types of referrals you get, and maybe where we are in terms of sort of diagnosis, pre-diagnostic counselling, and what we're doing afterwards. I thought I'd try and talk through, very similarly to Ben, what we've tried and learned in Bucks in our service, and trying to go through some of the issues that I feel maybe could help people think carefully about what they're doing and maybe learn from each other. So that's about technology, it's about expertise, it's about communication. And I am concerned, as is everybody here, about exclusion and bias. So if we go to the next slide. Okay, so for those of you who aren't sure, Buckinghamshire covers a sort of an interesting landlocked bit of the country, and we've got 2 memory clinics, one in Aylesbury and one in High Wycombe. And there's something relevant really about the logistics, as was mentioned about Cambridgeshire, in that we access a number of acute hospitals for scanning, both within but also outside of our area. So we map onto a variety of different NHS trusts, and of course everybody is sort of trying to do the same thing but slightly differently. So just as was described, what we did in Buckinghamshire is at the beginning of the pandemic, the services for memory clinic and to neuropsychology were stopped. They were suspended. We felt that was the right thing to do. What we then did is we started remote opening, and that was using digital platforms and trying to think about the initial memory clinic assessment. And I'll talk a little bit about how we try to do that and how you need to work through both the clinical contact and then the technical contact, and whether or not we've needed to make multiple phone calls to people and some practice issues around what we've used, which is Microsoft Teams. And then more recently in Bucks, we've started to go back to face-to-face, and that's actually in the buildings, and that's been very recent in the last two weeks or so. And that, of course, as everybody knows, is all about what infection control rules there are, how far apart we have to be, and how that works. So we're very much new to that. We've had to embrace technology, as everybody has, and so we're working through essentially Microsoft Teams, making phone calls, and then using some of the other sort of remote assessments. So remote mockers is what we've tried in Buckinghamshire. Learning fast is possibly the understatement of the year really for us in the team. It's really required us to pick up quickly what we can do and how we do it. And so what we've needed to do is think about, right, who does what? How many times do they do it? What's possible? And I think we're getting there, but the sense that you are learning all the time is a really critical one. You know, we are trying to think carefully through who's best placed to take that call, who's best placed to do the follow-up. And I would say a massive thank you to all of the administrators across the country who I think are having to do so much more. And we're definitely asking them to do loads with us in Bucks. The other thing I think has been really crucial and we've noticed is about teamwork. It's required an awful lot of leadership from all the people involved. I think memory clinics are always a really lovely example of MDT working within a variety of other structures, acute hospitals, community mental health teams, and for us in Buckinghamshire, psychologists actually sit within a separate psychological therapies team. And so we've had to be really open to everybody's concerns, thinking quickly and carefully about ideas and feedback. And I would really echo Ben's kind of emphasis on the positives, that whereas previously many of us have said, well, I can't make that meeting next week, which is in Aylesbury, we're now able to say, well, how about we have a 5-minute Teams meeting and we say what happened there, what should we do? So there are real benefits. I think the other thing is about being agile to looking at the data. And yes, I know Anna Forrest over in Cambridgeshire, so I can imagine she was quickly on to finding out what this was about. And again, in Oxfordshire and Buckinghamshire, we're trying to look at service improvement projects with trainees, looking at what does remote practice and remote neuropsychology look like. So next slide, please. Mentioned the vast variability, but I would also mention that even across Oxford Health, which covers Oxfordshire and Buckinghamshire, there's an enormous difference in the availability of clinical psychology, the roles we have, and the criteria for the work we do. There's commissioning differences in priorities. So for us in Buckinghamshire, we have a high number of referrals for neuropsychological assessment, considered to be an important part of the memory clinic sort of process, and we have therefore adapted the types of neuropsychology assessments we do to fit with that high demand and to fit with that model of sort of high numbers coming through. We also in Buckinghamshire, as a group of clinical psychologists, see people with young onset dementia, which isn't the case in Oxford, for example, where there's access to a different service. So you're having to work with what you would normally do. We work in 6 different settings for memory clinic, and as you all know, there have been, memory clinics are sometimes in GP practices, they're sometimes in the north of the county, and there are 3 of us, whole-time clinical psychologists across the setting. We've got assistant psychologists in memory clinic, and that's been an interesting thing to look at in terms of how we work within their competency and their capacity, and how we make sure that they are also part of the team, because they present with an interesting set of skills, maybe high sets of skills in using cognitive assessments and remote assessments, but maybe in terms of decision making and in terms of responsibility need to be cautious about where they're placed. Our service has a shared feedback model, and again, another positive, much more straightforward to join a consultation as a member of the multidisciplinary team via a remote setting, rather than maybe go and try and fit it in a clinic somewhere across the county. And we've got a small role in CST, cognitive stimulation therapy, and post-diagnostic support. And that's not something I'm going to be talking about today, but I think it's something when we think about remote diagnosis, then remote support as part of the other part of my job of how are we working therapeutically in a remote setting. And we've also been really successful in Bucks in translating our CBT for carers intervention online, and actually working with our local IAP team to provide something where we've had some really good feedback about getting groups of carers together and working through that. Next slide, please. Okay, what do I think is possible? What have we found? We've used telephone triage, we've used the IQ code, and we've used the MOCA. And we've developed a remote neuropsychology assessment where we have adapted the choice of tests. We've put things on PowerPoint to ensure fluent delivery. And we are trying to work with copyright, which is one of the big issues. And what we have had to do is use visualizers, so essentially a little webcam to look down on the actual stimuli rather than copying them into PowerPoint, which is a bit of a pain because it means that the flexibility maybe of having something that all of us can use is limited. I'm not going to talk precisely to neuropsychology. I know there was a lovely MSNAP webinar with Sarah Garney and Rebecca Pos, and I suggest you have a look at that, as well as some of the stuff from the Division of Neuropsychology in terms of really pinning down what does remote neuro look like. What have we done with the referral lists? Well, the questions for neuropsychology are often quite broad, and we've needed to go back through those that we stopped and really think carefully about what is being asked and is that possible remotely. So for those of you who maybe are used to doing driving assessments, or those of you who are used to maybe thinking about differentiating dementia and depression, we've been really thoughtful about, are the confounds that mix with a remote setting going to be too difficult for us to make those choices? And we're still learning, and we're still keen to try. We're looking at follow-up assessments. What are we doing with our mild cognitive impairment people? Can we compare a face-to-face neuropsychology with a remote piece of neuropsychology? And I think, as Alistair mentioned, actually we need to have, yes, an eye to the validity and the reliability of these standardized tests. And of course we do that. But there's also something very pragmatic of how long can we make people wait when there's an awful lot of other information that we can bring to bear on making those diagnoses. And we also need to be really thoughtful in saying, well, if we're willing to do this remotely, we need to actually think carefully that this is good enough. We also really do need to think about clinician attitude. It's actually really difficult to change. Change is something that us psychologists are usually really interested in, and we have to own ourselves as a profession that we have, in many cases, been very married to doing things in certain ways. So I think it's really important to think carefully about how agile we are to change, and then how good we are at using technology. I think we do need to move in that direction. And we've seen a vast change, as I'm sure everybody has, between people saying, how do I press this on Teams? It's not working, to something which is, let me share my screen and would you like to see this? And let me use the chat facility, etc. Okay, next one. I think this probably talks to Alistair's point about what we know clinically, where our expertise sits. To translate to remote practice, you need to work carefully with what you're already doing. So we set up some focus groups about our clinical psychology input, about what's usual practice and what we'd miss. And actually, universally, we said we'd miss watching people walk to the room, because there's so much that you can think about as somebody walks to your clinic room, and how do they negotiate the door, and how do they make sense of what's happening. We are aware that we're needing to make some exclusion criteria. Expressive language problems remotely with possibilities of Wi-Fi interference are really difficult to work with. Frontotemporal difficulties, that sense of how do I hold apathy or attention or disinhibition? How do I even make sense of that? And how difficult is that for carers if they're trying to get somebody to use something which requires quite a lot of focused attention? And we've mentioned the idea of movement and the clinical work there. We've done trials. I've had to get my husband to practice to see what happens if I get him to do a tapping test, and how is he able to copy a drawing. And then we've had to learn some really clever things, like if you're going to do a remote memory test, you have to make sure that somebody doesn't write it down. So we've had to adjust, whether or not they've got a pen and paper, and then if they've drawn something, whether or not they actually rip it up in front of the screen, so we know it's not there in front of them when we come to the follow-ups. There are, of course, massive confounds when you think about the validity of the test. Is it sufficient to ask somebody to give a verbal response to a problem that you're asking them to do? Or are we missing the initiation of action by actually only doing it verbally? And this is where we need to learn. Are there ways we can use different webcams? Adapted neuropsychology really does need expertise in interpreting the scores. How do we think carefully through what we've just recorded versus what we noticed? The assistant psychologists have been incredible for us in terms of helping us set up the technology, helping us talk through all of the work that we've done. And we've tried to emphasize that for the memory clinics, where with us in Bucks, some of the assistant psychologists have been doing the mocker remotely. And that's been really helpful in getting them to think through the underpinnings of what a cognitive test is from a cognitive psychology perspective. It's all about translating to something that's good enough. We've had to be really quick to think about how people are going to do things. Okay, next slide. The communication we've increasingly looked at and thought carefully about. There's an added complexity to clarifying what you're doing when somebody may have had a phone call to explain that it's going to be a remote practice. They may have a phone call to see if they've got Teams. They may have a phone call to check Teams works, and maybe a Teams call. And so we're really keen to think about this. What we've realized is that explaining what you're doing and asking for consent is a rolling need, and there are some power differences that we are having to think about how we negotiate, which is when a family member says, yes, of course they can take part, I will use my Zoom system. And then the client themselves may feel shoved in front of the computer and suddenly is talking to something. We've got the same problems, but they're different. We've had an experience of an assistant psychologist having somebody come quickly to the screen and say, please don't tell my mum this is a memory test. And then us thinking, maybe that did used to happen in all of our clinics, but there was something about being brought into the building which maybe was different to this being in your front room. We've also needed to think carefully about how we manage distress when noticing people being upset. And how do we do that? how do we show empathy remotely? And that's where we're bringing our learning from some of our therapy work about needing to talk through it and needing to guide people that it's okay to be sad, that it might feel uncomfortable. And there are benefits. People can say a lot more when they're comfortable in their own home. People will explain what's happening. And so we're looking at the pros and cons. Next slide. And of course, we're thinking about exclusions all the way through. It's one of the principles Ben spoke at the beginning. Equality of access is a critical element here. The British Geriatric Society and Gerontology Services are talking a great deal about how acceptable digital practice is for older people. And we're walking that line between our incredibly able older people who are very efficient, you know, using U3A, really adept with Zoom, with Skype, with all sorts of other things. But equally, there might be those who are concerned. I'm interested in something called Sparko TV now, which is where you get to maybe use the television to have things come through. So we need to be thinking about these things. Having access to technology is about resources. Having resources means that we need to think carefully about those who don't have those resources and the intersectionality really of different groups who don't have the money for Wi-Fi, for computers. And also there's some interesting things like some of the services are set up whereby you wait in your car before you come to get your blood test, or blood tests in the car. I've had a number of people saying, I don't have a car. How does this work? How do I get there on public transport? And we've got this issue with risk. Working with multilingual and BAME groups, absolutely. We need to look very carefully at how we use our interpreters, particularly with assessments and the validity of assessments. And so that needs to be thought through very carefully. We also need to think again about what this process is about for people in different cultural groups and how it feels to have somebody relatively powerful, tie or no tie, in their living room, and what, you know, that might mean for them. And we need to be thinking very carefully, of course, about the selection of tests. For us in neuropsychology, we've traditionally used more visual tests when we've known that language was difficult. Visual tests remotely are actually a little bit more complicated. So next slide.
Thank you, it's Alistair. I'm sorry to interrupt. I'm conscious of time. We're just sort of, if you could just finish off quickly so we can move on. Plenty of time at the end for discussion.
Fantastic. Thank you, Alistair. So yeah, absolutely. What next? Many things. Let's think about how we make it more efficient. Let's think about how we research it, and let's think about how we change ways of working. Learning what's new is really the key thing. And I think it's about being brave.
Becky, thank you very much indeed. That was a fantastic and positive and uplifting summary of what can be done. Thank you very much indeed. There were a couple of questions that came up during that, one specifically about the MOCA, and we'll come to that, but the issue of do we pay for that? And of course the MOCA, you'd actually to use the MOCA, you pay to be trained to use the MOCA, and if you do it, it comes back to the issue of that, and perhaps we could come back to that. And there was a more general question we could come back to later, Becky, of how you have adapted the work. Just something as well that strikes me as you're going through those fantastic examples that you give. One issue, and Ben, this is something you'd mentioned before, and that is training and learning for people using for clinicians using it, and people have talked about a website manner, and how do you develop a website manner using the technology. So Becky, thank you very much for that. It's a great overview. We're going to move on now. We have a couple of minutes to spare, so it's a great pleasure to introduce Dr. Jeremy Isaacs, consultant urologist from St George's Hospital, and also the clinical director of the NHS London Dementia Clinical Network. And Jeremy and his colleagues Laura and others, and Helen, have done a fantastic amount of work over the last little while, looking at guidelines not just for remote consultations but for imaging. And Jeremy, you're going to give us an overview of some of the issues around brain scanning and imaging. Over to you.
Thank you, Alistair. I'm just going to share my screen. Great. Can you, Alistair, can you see my screen? Are we good to go? Great. Okay, thank you. So yes, thank you very much for giving this opportunity to talk a little bit about imaging and how it might be changing in the current era that we're in. So we're in a new normal now with COVID. And what does this mean in terms of diagnostics? Well, it's not a secret that there is reduced diagnostic capacity across the NHS. And we're confronted with a need to change the way we're working to protect everyone. So to minimize non-essential travel and contact, and that especially applies to medically vulnerable people, of whom many people with dementia will be in that group, and also healthcare workers, so protecting us and our colleagues. And I think what that means is that we need to really scrutinize what I call discretionary medical activity. So that's things where there's a choice between whether we do something or we don't do something, to make sure that it really adds true value. And also we need to make maximum use of information that we have already, that's already been acquired during the patient journey. So what does this mean in practice? Well, I'm sure many of you are finding there are longer waiting times for scans. So this should be prompting us to ask the question, well, is there already a scan that's been performed during the lifetime of this person's symptoms? And Ben alluded to this earlier. And I think it's really much more important that the scan was performed at some point after the patient developed their symptoms, rather than being necessarily within the last 3 months or the last 6 months. Was it done during the lifetime of these symptoms? And I think we should be asking ourselves this question: can imaging be avoided altogether in some cases? Can we make a diagnosis without a scan? Or can we make a diagnosis before a scan and trust our clinical judgment, as Alistair was talking about? And can we, in addition to that, reduce clinical uncertainty through peer-to-peer discussion, which actually this new virtual world that Becky was talking about has made more possible and more feasible? So I want to tell you a little bit about a project that we ran last year in the London region. This was done in collaboration with South West London STP. And this was done before the COVID era, when we were all still meeting face to face. But I think the learning from it would apply equally, perhaps more so now we're in the COVID era. So we ran a pilot of a multidisciplinary meeting that ran every 2 months, where we had people from clinicians from memory services, neuroradiology, and someone from the cognitive neurology service at St George's Hospital. And the meetings ran approximately for about 90 minutes each. And over the course of that, the 4 meetings, 42 patients were discussed. And the average number of cases presented in each meeting was 11. And most of the cases were brought by memory service practitioners. There were a few that came from the neurology service. And about 1/5 of patients were under the age of 65. So this will tend to be something that will be of great use to people with younger onset dementia. But of course, it's still been very useful for people in older age groups as well. And most of the questions that come to the meeting are whether a clinician has seen a patient, has a query about the diagnosis. And usually they want to establish some sort of correlation between what they're seeing on the scan and what their clinical impressions are. So what happened during these meetings? Someone from the network sat and observed the meeting. So in about half the cases, all 3 professionals are involved in the discussion. So you have a neurologist, you have a memory service clinician, and you have a neuroradiologist. So this shows that most of the time, or about half the time, this is a genuine multidisciplinary discussion. And in about 50% of the patients that were discussed, that led to a firm diagnosis being achieved, where the clinician wasn't sure about the diagnosis prior to the meeting. And you can see the spread there of diagnoses that were made. And then a further 7% of cases, a diagnosis had been made, but it was changed as a result of the discussion. So 57% of the time, there's a shift in diagnosis. Now that's better than amyloid PET, by the way. And I'm not going to labour the point because of time, but there are a number of other outcomes that come from this that we observe. So people being an unnecessary scan being avoided, an appropriate scan being selected, and occasionally patients moving through to other types of investigation, to other types of referral. And there's a web link which I think Vicky will put on the chat for you to see if you want to read the paper that we wrote. So that's the easy bit. Working together, working collaboratively, using digital technology to link people remotely from different departments to share expertise. Here's the hard bit. Can we adjust the way that we work clinically, given that we need to think more carefully about imaging? And what I've done in the next few slides is set myself a challenge. I'm challenging myself here. Why do we do scans in people with cognitive symptoms? What's it really all about? What are we looking for? Is there a way of going back to the first principles and reconsidering that? And what I'm going to show you is a personal view. I'm not asking anyone here to change their practice, merely to reflect on some of the things that I'm going to propose or suggest here. So what does NICE say about brain imaging dementia? So it says offer structural imaging. Now, offer is a strong word in NICE terminology. It means you've got to tell the patient this is something you're recommending. And the purpose is, quotes, to rule out reversible causes of cognitive decline and to assist with subtype diagnosis. But there's a get out clause, which is unless dementia is well established and the subtype is clear. So what that's telling us is that if you are confident in your clinical diagnosis and there is a, quotes, well established dementia, then maybe you don't need to offer a scan. Now, NICE doesn't specify whether CT or MRI is preferred, except in suspected vascular dementia, because the vascular pathology is shown rather better on MRI than on CT. And that might be something helpful if you're struggling with MRI waiting times. Is CT a bit more accessible at the moment? It's a shorter acquisition time. Is that safe for patients? So in response to that NICE terminology, here are some questions. How often does brain imaging actually demonstrate a reversible cause of dementia? I don't have the answer to that question, but it's low. How good is brain imaging at confirming the subtype? And the answer is probably not as good as we think. What does well-established dementia actually mean? I think that's left unexplained in the NICE guideline. And when in the diagnostic process is brain imaging actually needed? Does it need to be done before you give a clinical diagnosis, or could it be deferred until afterwards? Because the purpose of a clinical diagnosis is to enact a care plan. Much of that care plan isn't particularly dependent on the subtype, and even if it is, you can always adjust your care plan if the subtype changes after further investigations. Now, we don't do neuroimaging in the diagnosis of all brain disease. So I've listed here, I just had a quick think, what sort of brain conditions do we not do scans in routinely? I've listed some there. I just want to talk a little bit about Parkinson's disease, because that's a fairly kind of canonical organic brain disease. So why don't we do scans in Parkinson's disease? And in fact, NICE is very clear in the Parkinson's guideline that you should not be routinely doing structural imaging in people with Parkinson's disease. Well, the reason is that the phenotype of classical Parkinson's is due to a specific pathological process, which is nigrostriatal dopaminergic neuronal degeneration. And that doesn't show up on structural imaging. You can't see it on the CT and MRI. So you can't rule in Parkinson's disease with a scan. Equally, other pathologies can't generate the classical phenotype of Parkinson's disease. So you don't need to rule out other diseases because they won't be present in someone who's got a classical Parkinson's phenotype. So can we transfer this to dementia? So let's start with rapidly progressive dementia. I think it'd be pretty hard to justify not scanning someone with a rapidly progressive dementia because there are things you really need to know about because they're going to inform you on prognosis like CJD. There may be treatments available if it's a brain tumor or hydrocephalus. And then you might have someone where things are progressing slowly, but your assessment shows that there is something that could definitely be structural. So for example, expressive dysphasia in someone who's got right-sided vision flare. You're going to want to know what's going on inside that person's head. What about progressive frontal lobe disorders? So these can be mimicked caused by slow-growing tumours, such as meningiomas. So if you've got a patient who's fit enough for surgery or other oncological management, they need a scan. Now, the urgency of the scan depends on the speed of progression, as it does in any medical presentation. What would problems arise if we fail to make a diagnosis of behavioural variant FTD? So I've used an abbreviation, BVFTD, that's behavioural variant frontotemporal dementia. Well, in fact, the social ramifications of frontal lobe disorders are similar whatever the cause. The way that we manage and assist patients and families with frontal lobe disease is the same. It doesn't really matter particularly what the underlying cause is. But behavioural variant FTD is often a genetic disorder, and up to 20% of people with this condition will have a mutation, usually in C9orf72. The prevalence of that depends, or the likelihood of finding that depends on the extent of the person's family history. In my opinion, genetic testing should be discussed with all patients with behavioural variant frontotemporal dementia. And if you find a mutation, it means that family members can be offered predictive testing, and that can facilitate reproductive choices. So I think it's quite important to make this diagnosis and make it confidently, so that because there is a care plan that's specific to the subtype. Now, I think it would be inappropriate to send genetic testing for frontotemporal dementia genes until you've excluded structural pathology. So I think if you've got someone where you're suspecting frontotemporal dementia, there are family members who might be implicated by genetic testing. You need to scan them promptly so you can get on and talk about that. What about primary progressive aphasias, like semantic variant PPA, for example? Well, these reflect a relatively focal process in the brain and therefore could potentially be mimicked by a structural lesion. And we know that tumours, brain tumours in the dominant hemisphere will often affect language functions. So again, if you've got a patient who'd be well enough for surgery and other types of treatment, they need a scan. Dementia of Lewy bodies. So if you look at the revised McKeith criteria, they require dementia plus at least 2 of cognitive fluctuations, visual hallucinations, REM sleep behavior disorder, and Parkinson's. Now, that combination of features cannot be caused by a structural lesion. It's too diffuse. And so I think that DLB is a diagnosis you can make clinical. And you can always do a scan later if you need to, if you're worried about something that could be mimicking it, but the pickup rate will be lower. What about memory disorders? So my view is we shouldn't be scanning people with functional or purely subjective memory complaints. The pickup rate will be low and you're exposing the patient to the risk of iatrogenic harm. The canonical anterograde amnestic disorder associated with Alzheimer's disease localizes to bilateral hippocampal dysfunction. And in my opinion, this is highly unlikely to be caused by focal structural pathology. If you think about it, you'd need to have simultaneous lesions in both hippocampi that don't cause anything else. So they don't cause seizures, they don't cause other motor symptoms, and they have to progress at exactly the same rate as Alzheimer's disease. That's rather unlikely. So what does this mean in practice? So let's take someone with amnestic mild cognitive impairment, which in some people is a prodromal state of Alzheimer's disease. Well, remember that MRI, and you could put CT in the same box as MRI really, it's a prognostic marker, it's not a diagnostic marker. And so what I tend to find when I talk to patients in whom I think they've got MCI is that after discussion about what the role of imaging is and the role of other tests, often people will opt for watchful waiting rather than having investigations. What about Alzheimer's disease? Now I'm pushing into controversial territory here. So this what is Alzheimer's disease? This combination of anterograde memory disorder with deficits in at least one other of parietal, executive, or language function. So to get that, you've got to have involvement of multiple areas of bilateral cerebral cortex without significant subcortical features, without non-cognitive features, without mass effect symptoms. It's very, very unlikely that that pattern could be mimicked by structural pathology. So in my opinion, the diagnosis of a canonical presentation of Alzheimer's disease can be given prior to imaging. Have confidence in your clinical diagnosis. People on this call will have seen patients with these conditions hundreds or thousands of times. Have confidence in your clinical skills. And you can always do a scan after the diagnosis if you think it's needed. Finally, vascular dementia. So the diagnostic criteria for vascular dementia do require the demonstration of cerebrovascular disease on imaging. And the predominantly subcortical features of vascular dementia can be mimicked by other diseases that affect the subcortical region and the white matter. So for example, HIV encephalopathy or progressive multifocal leukoencephalopathy or CNS lymphoma. And some of these will be treatable. So if you've got a patient with a significant subcortical syndrome, what do you mean by that? Cognitive slowing, executive dysfunction, apathy, gait dyspraxia that's different from Parkinsonism. It would be hard to justify not scanning a patient. Again, unless they're too frail to justify intervening if you find reversible pathology. So in summary, COVID-19 requires us to think differently about diagnostics. We should share expertise to ensure we get the best value from the tests we do. Amnestic MCI, typical Alzheimer's disease, and DLB are clinical syndromes which are very rarely mimicked by structural pathology. So I pose the question to the audience, can we make a diagnosis first and then always do a scan later if needed? Whereas behavioural variant frontotemporal dementia, primary progressive aphasia, and vascular dementia are more likely to be mimicked by focal structural pathology. And a scan should be performed if the patient be well enough to intervene should you find a treatable cause. And I will stop there. Thank you, Alison.
Jeremy, that's absolutely fantastic and a really thought-provoking summary of what's an incredibly important area, and just reflecting in my practice, many people to whom I've spoken, older people and their relatives actually don't want to come up for a scan. They say, no, we're happy to have it. And I think the sense of having a brain scan, as you describe, somewhere in the loop of that diagnostic pathway rather than being a block at the beginning. And we see, and certainly in the memory clinic projects that you've done, Jeremy, in London, and others have done, the frustration that some people have, it's 6 weeks to get a scan, then 6 weeks to get a result, and then you do something. So I think you've very important to have that as part of the loop. And I guess one thing that just struck me when you were talking is the ease of doing these things. If it was much more difficult to organize a scan, if you had to be in hospital for a week or something like that, we would be much less likely to organise it. So there's something about the ease of access is important. So Jeremy, thank you very much indeed. There were a couple of questions that came that we could have a general question about, are we over-reliant on scans? And I think you've answered that, and perhaps we could come to that in the discussion. So we're going on to the last presentation now, and it's a pleasure to welcome Ella Robinson, Senior Policy Officer at the Alzheimer Society. And Ella, you're going to give us that essential view from the service user experience of the remote consultation. So Ella, thank you very much for joining. This is a really important issue, and over to you.
Thanks, Alistair, and thank you everyone for having me. So as Alistair said, my name's Ella Robinson and I work in the policy team. To give a bit of background, I lead on our diagnosis work, and I've recently completed a report on the dementia pathway, which includes a section on diagnosing well. However, obviously now COVID has changed everything, and there's loads more work to be done on what diagnosing well actually looks like in the new context that we find ourselves in. So this is something that we've started to look at Alzheimer's Society, and I'm going to use the information that we've gathered so far to give you a bit of an overview of the challenges and the opportunities from the patient perspective, as well as some ideas about how we can move forwards. Please can I have the next slide? So gathering the information. As I said, we have started doing some engagement, and to date we've conducted a review of Talking Point. So that is our online community where people can share their stories and learn from each other's experiences. We've held interviews with people affected by dementia who have experience of remote consultation and diagnosis. And we have utilised information from focus groups that we've conducted on draft patient information sheets. And we've engaged with our colleagues in operations who are quite often involved in local and regional work that's going on. So the feedback that we've gathered to date has been fairly consistent, and there are some clear themes emerging which hopefully we can learn from. And we are also going to be continuing to look at this and conduct some more research. So if there is anything that we can do to support with the development of dementia-friendly remote assessments, or any questions that you'd like us to look at as part of our research, please do get in touch with me. My email's on the slide. Next slide, please. So what are people's concerns? The biggest concern that we've heard so far is the quality of assessments. People generally felt that the intent of offering video consultations would be helpful in some scenarios, but not for assessment purposes. And this was predominantly due to people being concerned that a professional might not be able to gain a full insight into a person's symptoms over a telephone or video call. This kind of included concerns around professionals not being able to assess people's body language or eye contact. And this was also combined with concerns that people had about the ability of the patient to follow the assessment as well as they would have done in a face-to-face scenario. This has already come up, but people questioned how problems with hearing could be supported remotely. And people did also feel sometimes that remote consultations felt impersonal. One person expressed concern that professionals wouldn't be able to appreciate her mother and get an overall baseline both clinically, socially, and as an individual. You'll see on the slide there that I've picked out some quotes just to give you a bit more insight into the feedback that we've received. I'll leave you read them in your own time. I think hopefully we can share these slides after, but I'll just read the last one out. I think telephone consultations have a place in some routine situations, but they have a lot of limitations. My father had his first memory clinic consultation by telephone and used his charm to pull the wool over the nurse's ears. Subsequently, we have had a reassessment face-to-face at home with a very different result. Common sense tells me that the telephone is just not good enough to use for a diagnosis of a complex condition. Next slide, please. So accessing remote assessments was another concern people had, and this has already been touched on, and I know you'll all be familiar with this particular challenge, but people did voice concerns about a lack of access to the internet or a lack of digital literacy. We heard that if services or family members were not offering or were unable to offer the right support, some people would not have been able to engage in the assessment or wouldn't have felt comfortable to partake in the assessment. people did tell us of examples where they didn't have enough guidance. So one person recently diagnosed said he only had a brief email, despite the fact that he finds processing requests challenging. He said the experience wasn't a good one and required the support of a carer to relay what was being asked. Again, there's some more direct quotes on the slide, but one woman said, "Both my parents are terrible with technology. So if I hadn't called the memory clinic first and given them my details and then been able to go over and physically set up the video call, I don't know how they would have managed to get that set up." And then the third concern that people reported was the lack of choice in how the appointments were conducted. So people really did value being able to have a choice of face-to-face if possible, over the telephone or over video. We found that some people hadn't been given a choice, and we also found that people generally preferred video over telephone because they found it more satisfying to see a face and not just hear a voice. There's also a quote on the slide about a woman who talks about her husband receiving a diagnosis over the phone. She said she wouldn't recommend this method to deliver such a serious diagnosis. Next slide, please. So the benefits, what do people think the benefits were of remote consultation and diagnosis? So it's somewhat contradictory to the previous concern was that some people found it positive that they're in their own environment. They value being in the comfort of their own home, not within a busy environment when processing the news. We found that people said they didn't have to worry about people seeing them upset. And I think this clearly demonstrates the importance of having a choice. So some people might want remote appointments for some of their appointments, but not for the when you're giving the diagnosis, and others vice versa. So I think that was something key that we really picked up on. Another benefit we found was that the value of receiving a diagnosis was actually paramount for a lot of people, regardless of how the appointments were conducted. So some people who are in the middle of the assessment process when lockdown happened described feeling in limbo and were therefore relieved to be able to access the diagnosis, even though it was remote. One woman told me that she wasn't sure how long she would have to wait otherwise, so she just wanted to do it. Generally, that was the case. People preferred having virtual consultation if it was the only option offered. So the next slide, please. So travel time and parking was another benefit. People valued not having to travel long distances or find parking, particularly if they lived in more rural areas. People valued the convenience, and one person actually said that it saved her and her mother having an argument about who drove there because they had been concerned about her mother's ability to drive safely. Next slide, please. So going forwards, overall, I think it's fair to say that we had slightly more challenges than opportunities, but I think that's fairly inevitable given that this is quite new. We did hear some things that could have been done differently that would have improved people's experiences. So one of those things was clarity on waiting times and giving people notice. So while people were appreciative of the fact that what happened was nobody's fault and they were just victims of circumstance, they did say that getting clarity on if and when they could get an assessment would have made a significant difference, particularly as people reported deteriorating symptoms over the course of lockdown. One person said once they were able to have an assessment, it was fantastic, but they basically got a phone call to ask if they were free the next day, and she didn't think that was enough notice. Another thing to think about moving forward is prioritise video over telephone. I think I've said this a few times now, but people valued being given the choice. And generally we found that people preferred video over telephone, and some people who had telephone assessments said it would have been better if it had been conducted over video. Positive communication and support to access appointments. So our colleagues in operations said that people would be more likely to choose remote options if the language was more positive rather than portraying it as a last resort. So I think if any collateral that was produced could kind of touch on that and alleviate some of the concerns I mentioned earlier, people might be more inspired to kind of feel the value of having it done remotely. Key there is having the right support. People valued having as much personalised information as possible on the pre-appointment information sheets, giving a contact number, for example, and the name of the professional doing the assessment. Whether the family member can join in on the remote consultation, and making sure that any information sheets are co-produced. one woman whose husband just got diagnosed said she was given excellent support by the memory service, and they were very helpful. I really like this quote actually. She said, "Never having done a video call before, I was quite nervous about it, but it all went well and it gave me the confidence to do it again. Sometimes you just have to make a leap of faith." And then lastly, offering face-to-face appointments when possible. So one person told me that her husband has trouble hearing, so she was given his diagnosis of frontotemporal dementia over the phone. She had tried to relay the diagnosis to her husband, but he won't believe her. She thinks it might aid the acceptance process if they were able to go to an official hospital building and he was told by a professional who had the authority to do so. The vast majority of people we spoke to said they would value a face-to-face appointment when they're able to do so, and people who had already had that said they found it really beneficial to discuss it in more depth and discuss treatment and support options. So that's the end of my presentation. As I said, I will be continuing to gather evidence, so please get in touch if there's anything that we can do to support you. And I think that it's Q&A time now, so I'll hand back to Alistair. Thank you.
Well, thank you very much. That's a very a fantastic overview of something that's very important, and I think you've described so well some of the positive experiences that we've heard, but also that very important aspect of some of the things we need to be very careful of, and it will be great to see the results of that, because that will guide practice. Just before I forget as well, next week we have a Dementia Choices Action Network meeting specifically looking at the issue of remote consultation and the virtual diagnosis. I think you're involved in that, Ella, and it would be great to be to hear that, because that's extremely important. So thanks, Ella. You've not only a fantastic talk, but you've given us a few extra minutes, so that's great. So double points for that. So we've had a number of comments. Could I just start by asking, is there anybody who from any of the speakers is there something pressing that you'd like to comment on what of any of the other speakers have come? I'm conscious that Ben has slipped away for a moment, but if there's nothing specific, what I might do, if I may, is go through some of the questions that have come up. And in fact, just when we go into the chat, welcome Dr. Nasruddin, the genius behind the mocha. So thank you very much for reminding us that the issue of the training has now been extended to December. So we're great fans of the mocha here, so it's great to see you there, and thank you very much for that piece of information, because it's been important. Just while I'm trying to gather some of the questions, I wonder, Becky, there was a question for you. It was a kind of general question about, you've probably answered this, but in summary, how have you changed the neuropsychological assessment battery that you have traditionally used on the phone? And I think that there is a tendency to sort of concentrate, and the commonest question that I'm asked is, well, what is the one test that we can do? Has it been validated? Are we going to do it? So in general, Becky, just quickly, just to get us started, how have you changed that battery that you've used?
Okay, so we have, I would say that this is for video use rather than phone, but when you think about key things that you can use, we felt that list memory and story memory were possible to use. So we've based it off our standardized battery, which was slightly briefer. So using things from the R bands, but you've got to be really savvy to the context that people generally tend to write things down when they're actually looking at something online. And so you have to make sure you set anything you use up with a set of instructions about not using a paper and pen, not writing it down. And sometimes you have to be quite upfront about saying, make sure you rip your paper, as I said. So verbal memory we found was relatively straightforward. Verbal fluency we felt could be done online. So your category and your phonemic is possible to do. we found that there are some aspects of visual copying that could be done, provided somebody had a camera and they were able to show their picture to the screen, but you have to have some additional instructions. So for example, if you put a screen behind you, you can't show it up to the screen because it doesn't come in and out of focus. So I guess in essence, you need to take what can be done the most similarly with the instructions you've got, and then think very carefully about the process of how you do it online. The obvious exclusions are one where there are interactive elements, so the blocks from the waist or any of the jigsaw or any of the sorting. And we are very conscious about the executive functioning tests that require you to follow a process. So again, like everybody said, you need to go back to your clinical expertise of asking questions away from a standardized test. Happy
Great.
to go through it. There's variations across the country.
Thank you. That's fantastic. And I know, Ben, if we can get the remote ACE, the information for that we'll send around. I mean, certainly I've used the ACE simply by, I know, Jeremy, you and colleagues in the London network have produced a PowerPoint version of the visual aspects of the ACE that can be put up. I did one yesterday, and I just, I put the pictures up to the screen. They wrote something, they held it up, I took a photograph of it with their permission. There was no, there wasn't any confidentiality issues of taking people's pictures, and that goes into the report. So there are a number of ways around it. So that's very helpful. There was a general question about post-diagnostic support and the things that are available. Ben, can I just ask you just to comment on what post-diagnostic support, and then Ella, I'll come to you if I may and ask from your survey what the perception of post-diagnostic support, and particularly we had a comment from Jane, who's an admiral in learning disability, and the importance of support there. Ben, what kind of support do you offer?
So our service offers a post-diagnostic support to everybody who gets a diagnosis of dementia, and we're still able to do that. So our memory nurses are still able to follow up remotely and do much of what they used to do. There's a lot of literature that people receive. There are other things like carers assessments that are available. But I think what's really struck me in Cambridgeshire is the loss of all of the other things that were actually often, I often felt, the most nourishing things. So the local day centres, the drop-ins, the church things, the plethora of community support that was available. And now seems to have so gone. So our memory nurses were amazing at knowing all of these tiny little niches and wrinkles around their particular patch that were available to support people. And it's those niches and wrinkles that we've particularly lost, I think.
Right. Excellent. Ella, was there anything on the survey that was it concentrated on the diagnostic process? Were there comments about post-diagnostic support?
It was mainly focused on the diagnostic process, but we have heard anecdotally about people obviously very concerned that they can't access normal support groups. And when our dementia support workers have tried to, send through some like rehab materials for physical exercises and things like that, they've not been able to motivate the person to actually do it at home. So it's definitely a concern, but the survey did only focus on diagnostic, although a lot of people in the face-to-face question said that they did want a follow-up so that they could discuss that in more depth than they did during the remote diagnosis.
That's great. A couple of questions, Jeremy. There was a specific question, probably not directly related to the COVID issue, but the issue of the DAT scan in Lewy body disease. And is that something that we overuse or underuse? Or in your mention of Lewy body disease, a technical question about should we use the DAT scan? And then a question about the other information, a specific question about the white matter load that we can see on, say, an MRI scan, and that related to prognosis. So a couple of quick questions, if you're able to help us on those, Jeremy, would be appreciated.
Thank you. Quick questions. Not sure there are quick answers. Well, of course, if you look at the revised McKeith criteria, the situations where a DAT scan is needed as a supportive biomarker in situations where you don't have enough clinical evidence. I think that will have to vary from person to person. undoubtedly there is variation around the country and around the world in the use of DAT scans, and I don't think I can give a clear answer other than that, what the NICE guideline says is look at internationally agreed consensus criteria for the diagnosis of different dementia subtypes, and they will guide you. So if you're struggling and thinking, should I be doing a DAT scan, look at the McKeith criteria, go back to them and chart your patient's features against them, and maybe you've got enough to make a diagnosis without needing a DAT scan. I think the question about, when should we be doing a scan to assess white matter lesion burden? And I think the answer is if the patient has features that suggest their white matter is involved clinically, then you want to know what's doing that. The question about whether there are alternative biomarkers that you could use instead of doing a CT or MRI scan, like looking at the retina or doing blood tests. I don't think that we're quite at that stage yet, but that's an area of active research.
Great, that's great, Jeremy. There was one question I'd just like everyone's thoughts on this, if I may, and that's around risk. And obviously, Becky, you've described a couple of issues around risk and the risk of tearing up the paper. Sorry, I forgot to do that in the ASI I was doing. I've certainly done a couple of phone calls, and I've been able to hear someone whispering in the background to give the answers, but you have to take that into account. And one person actually wrote down the 3 words clearly from the test of the mini-mental. I always think if people are able to do that, though, that's a very good indicator. And so it's actually kind of using that in the as part of the diagnosis, rather than saying, oh, it means it's invalid and we can't use it. So there are tips like that. But in terms of risk and coercion, and someone asked about issues of the private room and the trust and alert words. Becky, in terms, I'll come to everyone if I may, but in terms of that risk of individual, Becky, any thoughts or experience on that?
I think like everything, we're learning really fast. I think we have instituted an initial phone call to have that conversation about what's possible. And that's where you're able to say, do you have a room? Would you be overheard? What would this be like? Particularly for understanding people's social contexts. And that's really important when we think of the variety of homes that people live in and the family members they have, in terms of having children present and in terms of noise, etc. So we've managed that, but it's been ad hoc based on what's practical. We are gathering evidence regularly with a memory clinic huddle in terms of issues around maybe the loneliness or higher distress risks of people who seem to be on their own, seem to not understand what's happening, and that's usually captured in the original phone call. So we've had some discussion of whether people who are having carers coming in, how we might engage with any network they've got, and that's where we've made links with our CMHT if we feel we have heard something on the phone that's necessary. I think where we're looking at consent and understanding, and I've seen some of the comments around who is asking for this and who is getting the information and feedback. We're learning as we go, really. These are, as I said, sort of the same but different, but we haven't got that flexibility of somebody being in the room, so we're having to do far more questioning. We haven't got a risk assessment. I know somebody asked for a protocol. We haven't got one, but we are more active in discussing cases.
Right, excellent. And yes, I think in terms of everyone's familiar with the various risk assessments. Ella, could I just ask, in the survey, there was the example that you gave, a very good example of whether it was appropriate or not, I don't know, asking the relative to tell the person they had dementia of the frontal lobe type. I'm not sure if that's something that we would say was a good thing. Thanks for shaking your head, Becky, in agreement. Were there any particular issues, Ella, in the survey about coercion and things like that?
Not entirely. There were concerns sometimes from family members that it wasn't always clear whether they were allowed to sit in on the consultation. So that was kind of a point they raised in any pre-appointment guidance. Could they do that? And the other thing was that if the carer would say, oh, usually they ask the consultant whether they could put the phone on speaker, but maybe just a bit of clarity on the dynamics between family members and people before assessments would be helpful.
Excellent. And Jeremy, I think in terms of risk assessments and having to do a huge risk assessment and everything like that, it's probably something specific to the practice of psychiatry. You may not have it as much day to day in your urology practice, but in your experience, has that been an issue?
Well, I mean, in general hospital practice, patients are still coming up to a limited number of face-to-face consultations, and we have screening at the door to make sure that it's safe for people to enter the building and for the consultation to go ahead. I think I haven't got any further comments about that particular aspect.
Okay, no, that's helpful, Jeremy. And Ben, is that something that, as part of the survey, but that you came out and that you've seen worries about coercion and things like that?
Coercion with regards to what particularly, Alistair?
Well, you know, people sort of relatives doing things that, you know, that they could do on the telephone that they
couldn't do in clinic.
They couldn't.
Yeah, so I think we're all veterans of this in the clinical scenario where, you know, the relative will come in and say, "Don't tell mum if it's dementia." Well, you know, so I'm afraid and I'm sure everyone else in this call scotches that pretty quickly in the room, and I'm sure we would do the same on a video consultation or on a telephone conversation. I've done much less in terms of telephone consultation, so I'm not so well versed in that. But I think you know, I would always be. I've never in my career yet got to a position where I haven't been open and honest with the patient and told them the diagnosis. And yeah, so that is something that I guess I hadn't particularly considered about remote consultation, but is something to think about. Excellent.
Okay, that's fine. I'm conscious we've got a couple of minutes to go. Could I just go around and ask the speakers if they've any final reflections, and if there was one message that you wanted it's gone down a bit. It just peaked around 500 people who were here. It's gone down a bit, but if for the audience of hundreds that we've had, if there was one message, what would it be? I'll take in random order, just as they appear on the screen. Now, Jeremy, one message for your hundreds of fans who are listening.
I think if you're thinking about doing tests on patients with cognitive symptoms, always ask yourself the question, why am I doing this test? What am I seeking to rule in? What am I seeking to rule out? Is there another way of doing that?
Great. Ella, the one message from the survey about what many of the clinicians could learn?
I think it's the offering of choice. I mean, what really came back strongly was that it's the provision of a personalised service that people really value. So making sure there's choice before every appointment about how that appointment is conducted, I think would be amazing.
No, that's fantastic. And certainly in the work that we're doing, I think that choice is key. Thank you for that, Ella. Ben, a single message?
I think this is here to stay, and this is the future. And I would say embrace the positives. Let's make the best of a bad job and see what are really positive and good things, and maximise those.
Okay. Thank you very much, Ben. And Becky?
I think I would say before we pull to pieces the small problems with new ways of working, we need to be mindful of difficulties that we already had, and that these might offer solutions to that. And that's the case across standardized assessments, remote practice, people driving. So a bit more of a positive of look what we can do, not what we can't.
Well, thanks very much, Becky. So just in terms of the general things, thanks to everyone for joining. And as you say, Becky, that was going to be my first thing, is that think of the things that can be done. In many ways, this is an excuse to do things in a different way, to hone down the things that we're doing, not doing things just because they're easy. And Jeremy, as you say, only do something if you have something for it. And I think that would be key. I think aware of the risks and the drawbacks, but not making those risks as an excuse not to do something. And as everyone knows, when there's a new idea, it's easy. The easiest thing in the world is to come up with 10 reasons why it would never work. And I think coming and seeing the positives and looking forward, Ben and Becky, as you've articulated, and Ella, that issue of choice and running through the work is choice, and certainly that's key. As you say, Ben, we are here for the long term, whether it's COVID services and non-COVID services. I think that would be important, and I think embracing new ways rather than just waiting and a sense of sigh of relief when we get back to doing things that we always did, face to face and everything, and oh, thank goodness things are back to normal. I don't think they will be, and it does give us an opportunity, certainly in memory assessment services, perhaps to look at things that are we can do more in primary care. And I was speaking to a GP recently who said, there are people that I would never refer to a memory assessment service, and I'm not going to because of the things that we can do. So that's support in primary care. The role of the memory clinic, I think will be looked at. And Jeremy, if we were going to mention the treatment, the new treatments potentially available, aducanumab is making its progress through the Food and Drug Administration, and that would be the subject of another webinar, but things in the future, I think, being different. So perhaps it leaves me to thank very much the speakers, Becky, Ben, Ella and Jeremy, to colleagues Sinead and Vicky and Susie and all the colleagues who have made this possible. It's been a great event, and a date for your diary, 12th of October for the next MSNAP webinar. Enjoy the rest of the day. Thank you very much.